well, let's get started. Today, well, let me introduce myself. My name is Laura Evans. I am the Director for National and State Policy with Vibrant Emotional Health. We have a great featured speaker for you today. It is Seth Kahn, who's going to talk to us a little bit about anti-stigma campaigns. This is all part of the grand challenge that's been focused around other campaigns like recycling and seatbelts, breastfeeding, and anti-smoking. So I'm very much looking forward to this conversation. It's also International Women's Day, and we're going to hear from some amazing trailblazing women who are on the call. And speaking of the Crisis Jam, you can always go to talk.crisisnow.com to see over 80 hours of YouTube videos for the Crisis Jams. We have 74 national organizations. We have other countries participating. We have individuals with lived experience, Medicaid offices, policymakers, intersections of all of those. And so very excited for us to have a conversation today. Thank you for joining us. Just a reminder, if your calendar invite has fallen off, you can always refresh it with the links that are in the chat. And of course, you can go to talk.crisisnow.com, get the Zoom link directly, sign up for the newsletters, peruse those 80 hours of videos, go directly to a section you may need. There's a wealth of information. I think we've been having these for 3 years, 2.5 years. And I'm always directing people to go back to like, that was a featured presentation. So make sure you use that. Lots of crisis information in the news. This is a highlight. This is a screenshot from the Utah dashboard that was featured in the Kaiser Family Foundation news. And they use data points from SAMHSA, Vibrant, other sources to create some really great graphics to help showcase and help other folks kind of see the work that's been going on that you all do day in and day out. So really great article. I think we're going to drop the link to the chat if you haven't seen that, as well as an article from North Carolina Health News. This article was featured, and there's going to be a link in the chat. This outlined nearly 500 individuals who had to wait to get service. And so really highlighting the need to scale. So make sure you check that out. And that's going to lead us to our quote. And this quote comes from Ron Bruno, who's the executive director of CIT International. They have a white paper or issue brief around their organization, why their organization doesn't promote co-responder models. And so the quote from Ron here is that law enforcement should only be engaged in situations where there's a clear threat to public safety. So very interesting. I know a lot of communities have had discussions around partnering mental health professionals, social workers with police, and CIT International has a very clear issue brief and position that they believe law enforcement should only be engaged where there's a threat to public safety. So he's going to come back. He's presented on the jam. He's going to come back. Make sure you tune in when he comes next week. Let's go to the next slide. And so at this point, I will turn it over to Seth Kahn, who is with visionaryleadership.com to talk about the featured presentation.
Thank you very much. Can you hear me all right?
Yep.
Okay, great. Well, it's a real pleasure to be here. It's an honor. And I do want to start by acknowledging International Women's Day. It's a global holiday. And I just want to say, may your perseverance, bravery, grace, courage inspire you and motivate everyone around you. I want to just, honor the outstanding achievements of women across the world. So here's to progress, equality, and supporting one another. I'm going to be talking today about stigma, and the stigma in particular around mental health and substance use disorders. I am the lead for a grand challenge to eliminate this stigma across the nation. This is a national movement, and I'm going to talk about what that means in just a moment. But before I do, I want to just pause and ask you, what does stigma mean to you? How does that resonate in your life? Have you personally experienced stigma, either for a colleague, a loved one, or yourself? Just a moment. So let me tell you just a little bit about my own life. I have lived experience in this space, and I'll start by saying I'm not a mental health expert, but I am fully committed to this. I have been on a journey myself through the mental health world. When I was 10 years old, my mother developed schizophrenia. It was super challenging. The first 10 years of my life, she was a wonderful mother. I was very close to her, and suddenly she vacated, and she was lost to hallucinations, paranoia. It was really challenging. And this was in 1969, and there was no effective treatment for her. And my family basically fell apart. I moved out of the house when I was 16. I have a sister who has bipolar disorder who doesn't take her meds. My other sister and I do our best to keep track of her and help her out. My mother, fortunately, in the last 10 years of her life, did get good medication. That was in the 90s, and we had a wonderful relationship for the last bit of her life. But that's when I think of stigma, I think of all the times that we were challenged to find treatment, that people didn't want to talk about what was going on in our family, that we were treated as though we were less than, that something unusual was going on. And so that's my personal experience of stigma, and I carry that in this work. When we look at stigma, we are talking about the beliefs and attitudes that can have a devastating impact on someone's ability to get help for themselves or to get help from other people. Stigma is a word that many people have a problem with. There are people who believe the word stigma is stigmatizing itself, and there's some truth to that. And so we're challenged by that. But it's also a word that has been accepted in the research world. And so there's a tremendous amount of definition and research that's tied to it. If we're successful in eliminating stigma, it will be a word that we'll be able to eliminate from our vocabulary in this context. But in the current situation, it serves. So how did we get started in something like this? Well, in 2016, a report came out from the National Academies, and the name of that report was Ending Discrimination Against People with Mental and Substance Use Disorders, the Evidence for Stigma Change. And it's really thorough, it's free, it's available on the web as a PDF. I encourage people who are interested in this to download it and read it. They've done a wonderful job. And in that book, they divide stigma up into 3 dimensions. And I'm going to go through them one at a time here. The first is structural stigma. Structural stigma is stigma that's embedded in policies and laws. So when we say a policy, it could be a workplace policy. It could be a church policy. It could be a scout troops policy. When we say laws, we're talking about actual legislation. And the horrible thing about structural stigma is that it means that people continue to create stigma unknowingly, which means that they can have love in their heart, not wanting to perpetuate stigma, but simply by being compliant with the policies or laws that are involving them, they're continuing stigma. So we need to deal with that. The second area is public stigma. These are the conversations and norms that people have when they gather on a Zoom call, in church, in school, in the healthcare system, in the shopping mall, anywhere that people gather. How is it that they think about mental health and substance use disorders? And then the third area is in self-stigma, and that is in our own minds. You know, I had an experience with my mom once when we were at a dinner with my wife's family after she had come back. And even though my mother had taken her meds and was, 95% there, you could still tell something was off with her. Her hair was askew. She dribbled food on her blouse, didn't clean it up. And my wife's family loved my mother, embraced her fully. But I felt embarrassed by her at that point in my life, having that dinner. And that is self-stigma in here. My own stigma was actually keeping me from loving my mother the way I wanted to. And I had to do some inner work to deal with that. And I was fortunate that I was able to. But that's an example of self-stigma. It rose up in my own mind, and it prevented me from taking care of my mother the way I wanted to. All right, let's go to the next slide here. So we are using a rubric or a model that was developed by Dr. Christina Economos in 2001 when she did research on 4 areas where the United States flipped 180 degrees. Let's just hold on just a minute on the slides there. The 4 areas were recycling, seatbelt usage, tobacco cessation, and breastfeeding. And she studied how is it that the entire country, including industry, politicians, grassroots groups, citizens, how did they all flip to embrace this. And she identified these 10 key elements, which I'm going to go over at a very high level, but I've broken them down further into 3. So we can go to the next slide here. Thank you. And the first part is what we call building the case. And it involves framing whatever your grand challenge, your challenge that you're addressing as a crisis, because we know that people don't pay attention to things if they're just an aspiration. It doesn't move to the front burner because there's so much going on in our lives today. So we have to frame it as a crisis. We have to gather the evidence, and we have to make an economic case for why it's a good thing, in this case, to eliminate stigma. All right, the next one there, we're going to look at gathering allies. This is about building a plan, identifying champions, doing coalition building, and getting the government involved as early as possible. And we do that by inviting friendlies in the government now to participate. And the last section there, we call implementing the plan. And that's where we do advocacy, mass communications. And in this case, our mass communications are designed for the entire American public. So we're going to be leading this campaign with a focus on addressing and reaching 350 million people, every state and territory in the United States. And lastly, you want environment and policy change so that you're making it easier to do the right thing, basically. So we use this framework. Let's go to the next slide. Now, the next question is, how do you pull so many people together? And we do this with collective impact. And you could just kind of get a pace here. We start with a backbone organization. That's the Huntsman Mental Health Institute. They create a steering committee. The steering committee provides the vision, governance, and strategy. Now, I just want to say the most important element is something that's called the common agenda, because we're building an alliance of organizations. That means that you can't tell people what to do. They're going to do what they want to do, and they're going to stick to their mission. So you have to have a common agenda that everybody agrees on. And I'll come back to that in just a second. Then we have working groups, we have partners, and we have people who we call community members who are involved. This is the basic structure of a collective impact model. Our common agenda is to eliminate the stigma surrounding mental health and substance use disorders on a national scale. And we were able to attract, and just hold on this slide for a second, a very significant group of leaders to become our steering committee. And this is a really important thing. You know, people know that the Huntsmans gave $150 million to the University of Utah in 2019 to build the Huntsman Mental Health Institute. And so many people assume that the Huntsmans are steering this project, but they're not. The leaders of the organizations on your screen are steering it. We're in communication with the Huntsmans regularly. I speak to them weekly. But the people who are steering this grand challenge to eliminate stigma are the leaders of the Ad Council, the Association of State and Territorial Health Officials, the SHRM Foundation, the National Association of Social Workers, and so on. And so that's a point of real pride that we have so many top people from these amazing big organizations and some medium-sized organizations as well, like the JED Foundation and Shatterproof. And I will talk about how we incorporate small organizations and individual activists in a little while. Okay, so we have these working groups. Metrics is a huge lift for us because metrics do not exist for stigma in the United States. So we are actively raising right now millions of dollars so that we can put in place a way to gauge what is the level of stigma in those 3 levels I talked about, structural, public, and self, across the entire country. Next, we have funding. Funding, when I say we're raising money for metrics, we're doing that, but the funding group is not about the Huntsman Mental Health Institute. It's about our partners. We're building a network of thousands of partners, many of them very small groups, and anywhere someone has an active work program to eliminate stigma, we want to help them get resources. So we're identifying all of the resources that are available for mental health practitioners and mental health service organizations, and then we're going to help people obtain those resources so that our partners who are working on eliminating stigma have what they need to do the work. Next one. Of course, we have justice, equity, diversity, inclusion, and belonging as a critical element of everything we're doing. When we did our strategic plan, we asked this question of every single element of it, and we are building in equitable implementation. And we're also taking it seriously internally by making sure that our steering team, that big group of organizations at the top there, includes people from multiple demographics. And that includes ethnicity, but it also includes gender orientation, and it also includes lived experience and diagnosis. And so we want to make sure that the people who are making decisions are taking into consideration these different populations in our country. And of course, we have a communications working group, and we can just jump through these next two areas here. We have right now we have 150 organizations. 10 months ago, we had 15. A year from now, I hope to have 1,500, and we're going to be growing at that level of scale. Okay, next slide. So how does it work? How do we reach out across the country? Well, we do it through warm connections. And just go ahead and page right through this whole slide here. You can see a build where we reach out to the organizations that are working with us, and then we reach out through them to their social networks. And we just keep doing this over and over and over again until we're across the country. And that's exactly what's happening right now. We're in that process. Next slide. We are event driven too, because we know that when we bring people together for events, that not only do they get to spend time together, but we can pick a particular topic like children, youth, and family, or suicide prevention, or rural behavioral health, and we can map the field. We can understand what research is taking place, where is impact falling short, where are there gaps, where do we need evidence-based practices, where might there be a complete gap where we don't have anything, and how do we build out on that? So these events bring practitioners together to create what we call a community of practice, to map a field and then help us address it in a holistic way. So go ahead to the next piece there. What we see now, and you can just page through this entire slide, is what we have coming up. We have a journalism summit. It's actually coming up in September because we're doing it at the Carter Center in Atlanta, where we're pulling together journalists, reporters, and documentarians to look at how mental health is treated in the media, because we want to address, if you could just go back a slide there, we want to address mis and disinformation. The next on the heels of that in October, we have one on children, youth, and family, and that's because the mental health of children in our country has been declared a national emergency, and we felt a need to get on that as soon as we could. And then we're looking at early 24 for something on rural behavioral health, because we know that substance use disorders and suicides are extremely high in the rural areas of our country, and we want to include them as we go forward. All right, we can go to the next slide. So this is just a pictograph here of the people who are on our steering team. Let's go to the next one. One of the things that we're extremely excited about is the Ad Council. The Huntsman Mental Health Institute has signed a contract and made a commitment with the Ad Council. And if you're not familiar with the Ad Council, I know many people are, but Rosie the Riveter came from the Ad Council. Speaking of International Women's Day, I don't know if you're all familiar with her, but it's the woman with the kerchief on her head and her arm up, and she's saying, "We can do it." And that came out of World War II in this country. Smokey the Bear came from the Ad Council. I'm a camper, so I know Smokey the Bear. Every time I go in the woods, there's that picture of saying only you can prevent forest fires. And Friends Don't Let Friends Drive Drunk, another national campaign. Well, we've contracted with the Ad Council to work with them over the next 7 years, and my guess is it'll be longer, to provide a national campaign that targets our most vulnerable groups and grows into a campaign that includes the entire country. So we're very excited about that. Next slide. We're just at the very end here. I know that we're okay. Here we go. We're getting ready to go into the roundtable. It looks like that was my last slide. So let me just say that this grand challenge is something that I'm extremely excited about, as you can tell. And I know that you'll have my contact information on here. If anyone on this call is interested in connecting or being a partner, right now, where I just want to say, being a partner does not require a financial commitment. It's really more about helping us to overcome stigma. So what we're looking for is the creative, generative energy of the partners to think together, to create outreach together, to use toolkits together, and help us to eradicate stigma. So if that interests you, feel free to send an email directly to me, and I'm at seth@visionaryleadership.com. I'm sure you can get that through the podcast as well, but seth@visionaryleadership.com, and I'll just type it into the chat. And I'm ready to go to the roundtable. I think it's time to do that.
Perfect. Well, Seth, you gave us a lot to talk through. So I'm going to turn it over to a powerhouse on International Women's Day, Tanja Miles, who is an ordained minister, author, activist, veteran, and peer leader. She was featured in the 2003 State of the Union address and just overall crisis services maven. Tanja, please give us your thoughts here.
Well, first of all, thank you so much for, this crisis jam. These jams are so amazing. And I'm just so excited that, this is happening in our lifetime. So many good things are happening in our lifetime. And I think everything is just kind of aligning itself. It's like a divine alignment. And how cool is this? Seth says something that really struck me is collective action. In order for this to work, it's going to take all of us from the top down. I'm grateful for all of those organizations who have signed up to be a part of the Grand Challenge. Shout out to the Huntsman Foundation and that family for, leading this, and all the other people that are partnering with them. But at the end of the day, it's really going to take all of us. As I was looking at the word stigma just this morning, and basically this is what I found the definition. It says a mark of disgrace associated with a particular circumstance, a mark of disgrace. Those of us who have mental health diagnosis or who have lived experience with addiction, it's no disgrace. So we do not want people to feel sorry for us. We definitely don't want people to mark us, and we don't want people to mock us. And I think we have so much of that going on in our community and country because of misinformation, because of stigma, because if people think that if I have a mental health diagnosis, that means I'm crazy. No, it does not. Your brain is just like any other organ. And so we have to have these conversations in common because we have to address it. Look, we know that mental health and substance abuse is on the rise in every community. So the fact that we're all coming together for such a time as this is just more paramount than ever before. And so having a grand challenge, I think what it does, I'm a military girl, so it puts us all one mission, one mind, even though it's a bunch of us coming together from different organizations, different parts of the community, different ethnic backgrounds, different social economic backgrounds. But at the end of the day, we all want the same thing. We want to be heard. We want to be treated well. And I don't mean just by treating by just other people, but I'm talking about treatment when it comes to policies and what treatment looks like for, individuals, like myself. And so I'm so glad that we're having this grand challenge. And look, I believe that, when people see all of us working together, I think that's something that will address stigma, because a lot of times we think it's only one economic, demographic that has issues with mental health. Now, we know that a lot of our places in our community don't get the help and the resources that they need. And I'm so glad that, the Grand Challenge will address that. How do we get, good treatment and good quality of care in underserved communities or in our rural communities? But then what about the folks who just look like you and I? Because again, mental health and addiction does not discriminate from the curbside to the country club. And I've seen it when we address it as such and say, look, this affects all of us as Americans, all of us as human beings. And when we come together with one mind and one mission, I believe in our lifetime, we can eradicate stigma. We have to believe that we can flip the script on stigma when it comes to mental health and substance abuse. We're able to do that. We can do that. Are we going to have some hard conversations? Absolutely. Are we going to have some action? Yes, because we're already doing it. But it's going to take all of us for us. I got to say it again, that collective action is key. And so we have to talk to partners from a lot of the national organizations, but also what about those little community organizations who are doing the best they can with a budget of $500 a month, and they're trying to help 500 people. And so we have to make sure that as we get this information and we gather it, resources and hope and policy, that it's going to trickle down to the people that need it the most. And I'm so glad again that we're going to be able to address this in our lifetime, in our country, because people are hurting. People want help. But to know that when you reach out for help and people are going to mark you and call you a disgrace, that is going to change. I am not a disgrace. It is grace that got me here. It is grace that wake me up every day to give that same grace to other people. And that's how we all are in this conversation. So I'm just so excited that this grand challenge is here and that we get to use all the information and the resources to make sure that at the end of the day, it gets to the people that needs it the most. And I can't say it enough. Addiction and mental health does not discriminate from the curbside to the country club. It affects us all. And at the end of the day, we all want the same. We want to be respected. We want to be heard. We want to be valued. And I do believe that the folks on this call, we mean that. And we're going to work towards making sure that that happens in our lifetime, because we have to do it now. We have to work Wise Day because people are suffering and we are here to serve.
Thank you for that, Tanja. I think you may have given us several future weekly quotes. You all both addressed cultural competency. And I appreciate, Seth, the answer that you put in the chat. I actually want to just quickly, if we could, talk a little bit about the Huntsman's interest in this topic, because I think folks may not be aware of why the Huntsman family is interested in this.
Sure, thank you. John Huntsman Sr. started the Huntsman Cancer Institute and had success with that, establishing a world-class organization. And when he was dying, he told his children to think about what cause would be most meaningful to them. Meanwhile, one of his daughters ended up losing her life due to a substance use disorder. So the siblings of the David and Christina Huntsman, who are behind this initiative, this sister, she lost her life. Initially, the Huntsmans covered it up. They're a billionaire family in a very prominent position. They're Mormons out in Utah, where Salt Lake City, where that's their community. And they didn't want people to know that someone in their family had suffered so badly. They were affected deeply by stigma. And they did a lot of introspection, and they decided to come out all the way. And so they started telling their story to the press. They decided that they would start the Huntsman Mental Health Institute, and they decided they would take a personal stand against stigma. And now they're willing to stand on any stage, claim their sister as their loved one, and talk about why it is important that we all address stigma so that we can get the help that we need and that our loved ones and our friends need.
Can I piggyback on that? I had a—
Good to see you, Tanja.
I'm sorry.
I just said it's good to see you. It's good to see you.
Seth. I had a really good, candid conversation with the Huntsmans when I was in Utah some months ago. And I was really moved by their passion, not with their money, for real, grateful for that. But the passion is what, really drew me in. They were real, they were honest, they were open about what they wanted to do, and how they know that they needed others in the community to make this, dream a reality, because it's going to happen. But what also struck me is the openness about the challenges that their family faced. And at the end of the day, I realized we had more stuff in common than we did not. And again, I can't say it enough, is that we know that mental health and addiction does not discriminate. And so their story was compelling. It was sad, but it was also exciting to know that they're going to take something that hit their family really hard and now use it, for good, because they know that other families suffer just like them. And so I was very moved with their compassion. I was very moved with how, really strong-willed, if you will, that they are about making sure that in their lifetime this happens. It's not just about writing a check for them. It's about them using their time, talent, and resources to make a difference. And, they had me at hello on that one.
Yeah. Well, as you mentioned, it does not discriminate. And I think, we all have more in common than we do in differences. So something for us to keep in mind. Thank you both for this really great discussion. I'm going to keep us moving and just highlight the SAMHSA store. Hopefully these materials are back in shipping mode, but you can get up to 326 items from the SAMHSA store for free. So make sure that you are getting your printable materials. And while you're getting materials, feel free to get a t-shirt or a hat. We have a variety of colors, sayings. You can get it in English or Spanish, different logos. These are available for purchase, but you can also get one for free by participating in the hot seat. And so today's guest is Joy Brunson Insubaga. And Joy is the VP of RI International. Thank you, Joy, for joining us. Every year, many thousands struggle with suicide and finding a way forward. Their stories of hope and recovery have the power to help others and dispel discrimination and myths. And as we just heard, right, sharing your stories, being authentic, courage is contagious. So given that as our baseline, Joy, what is the name researchers have given to the influence mass media can have by showing positive coping in crisis? Is it A, the Papageno effect, B, the ripple effect, C, the Styron effect, or D, the Werther effect? Joy, talk it through, and you have all options available to you.
All options. Okay. Well, thank you for having me, and good job on my last name. I always want to give credit where credit is due. So I'm looking through and reading. I think I have an idea of what it is. And researchers have given to the influence. I'm leaning towards B, the ripple effect. But I can, I was just gonna see if I can ask the audience or see if I can get some feedback before I say my final.
Okay, if you have the poll, please make sure you participate in the poll. You also have the option to phone a friend, Joy, and all credit goes to David for helping me with your last name. And let's see, do we see the?
I think I'm gonna do the audience. I'm gonna see.
Okay, we have 62% with the ripple effect, 25% with the Papageno effect, 3% for C, and 10% for D.
Yeah. So that really goes along with what I was thinking. Hopefully, me saying that
you have
influence.
Chat.
But
you want to bring Vic
saying
up?
A.
Vic, do you want to come on camera and off mute and talk it through with us?
Yeah, I'm getting lots of responses for A. So I wonder if Vic can help me out here.
Hey, Joy.
Hey.
So yes, that would be the Papageno effect.
All right. Well, from another North Carolinian, I'm gonna ignore the other 62% and go with A.
Okay, she's gonna go off her original and off the audience and go with A, and A was correct. Thank you, Joy. Thank you, Vic, for coming in. And thank you. There's a link to the chat to actually a document that Vibrant has put together around the Papageno effect, which comes from a Mozart play or symphony. So definitely very interesting. And so there are a few examples of public stories of suicide attempt survivors prior to 2000, but then we saw pioneers like William Styron, who wrote Darkness Visible, and Kevin Hines, who many of you all know from the ripple effect. And sharing their stories have paved the way for hundreds of others to share their stories. So we always want to make sure that we are showing positive coping in crisis and letting folks know that there is hope. So thank you, Joy. You will be getting your free t-shirt or hat. And I'm going to turn it over to John Palmieri to give us an update from SAMHSA.
Thanks, Laura. Good to see you all. I'll be very brief today. Just wanted to let everyone know, and there's been some coverage of this in the press as well, that working with Vibrant Emotional Health, the Lifeline Administrator, we have been able to transition to 24/7 chat and text access through our LGBTQI plus services. So that was available since the launch of the pilot through phone 24/7 as of the end of September when the pilot launched. But chat and text had up until this past week had more restricted hours, but now happy to report that that is active 24/7 as of this past Monday. And then aside from that, really just kind of providing some general updates on planning that's underway, both from a budget perspective, obviously very deep in the 24 budget process, and also starting to think about 25. And then also a lot of conversations underway in support, in anticipation of the 1-year anniversary of the 988 transition. So lots more to come on that with respect to a number of activities that are being planned for right now. And I think that's it. Richard is actually on leave this week, so I won't be passing it off to him. So I will pass it right back to you, Laura.
Perfect. Thank you, John. And I'm going to send it over to Dr. Deb Pinels from Nashville to give us an update.
Hey, all. Nice to see you. Great conversation about stigma. Loved it. I thought that, and this ties right into it. Today for NASHBID, I am going to be talking about doing a spotlight on substance use and crisis services and access to co-occurring disorders. Very important, just reminding you that we do have some resources. I highlighted again, things that I've talked about on prior crisis jams. The compendium that we put together for 2022, From Crisis to Care, Building from 988 and Beyond for Better Mental Health Outcomes. There's 2 papers that you might be interested in, and these are available on the NASHBID website and SAMHSA website. One is looking at CCBHCs and urgent care, and the other is the Lending Hands, the partnerships paper that looks at behavioral health responders all together. We can go to the next slide. So we all know we have a crisis of our own and of sorts related to substance use across the country. There's some increasingly concerning data about rises in methamphetamine use, the ongoing opioid crisis that I know everybody is trying to tackle in different ways. Some studies out of the NIH looking at increased marijuana use and hallucinogen use in young adults, another very concerning trend that we're seeing. We also know that people with serious mental illness have a higher risk of having a substance use disorder, and this interplay is causing many of these crises, helping lead to these crises that the crisis services folks are going to see. So we have to be smarter and better at working on people who call on the phone lines, who might have a co-occurring condition, who might have a substance use disorder, as well as people that are responding and getting people to safe places when they need them. So access to care that addresses these co-occurring disorders starts from the very beginning. The more 988 grows and people call in substance use crisis, the more we want to get better at this work. Next slide. I just wanted to give a little bit of spotlight on methamphetamine because that's one of the leading drivers right now of many of the problems that we're seeing, and people who present, being somebody who still works in the emergency department, when people present sometimes with methamphetamine psychosis, they can look like they have mental illness. There's lots going on. People who present in crisis, we may not know fully always what's going on with them. Short-term impacts can include wakefulness, heightened physical activity, decreased appetite, faster breathing, heart rate and body temperature changes. But for people that are engaging in methamphetamine use long-term, we see other signs and stigmata. This is coming from NIDA, and I would encourage people to be familiar with this so that when people are calling in or when you're doing a mobile intervention, you're thinking about what's going on with this person: weight loss, dental problems, intense itching, skin sores, anxiety, changes in brain structure, function, confusion, memory loss, sleeping problems, violent behavior, paranoia, and also hallucinations. All these things obviously can interplay with what's mental illness. And so we may not know fully what's going on, but we need to think about from a the standpoint of out of hospital care and triaging, getting people into the right service so that they can get their needs met. Next slide.
Thanks, Deb. I actually want to make sure it's okay. So Kristen has dropped the link into the chat for where you can access all that information. Don't feel like you have to remember it all. I know there's a lot of good information. Deb, any final words before we go to the next section?
Yep, final words. We can go to just really thinking about this interoperability and future reports you're going to see. You can go to the next slide, actually thinking about all of this. We have papers we're working on now for this year, 2023 papers that are going to focus on access to care, advances in co-occurring disorders treatment, and technology advances. So stay tuned for those. And thank you, Laura, for the spotlight time.
No worries. We're definitely going to stay tuned for that. Always great papers coming out of NASHBIT. At this point, I'm going to turn it over to my colleague, Caitlin Davidson from Vibrant, and Steph Pasternak from NAMI to give us updates at the state level. Caitlin?
Sure. Thank you so much, Laura. So hi, everyone. Just wanted to share a few updates related to state legislation regarding 988 that are happening. Most state legislatures are still in session. So in Kentucky, over the last couple of weeks, we saw House Bill 516 get introduced, which would create a 988 trust fund and include special license plate fees. So I know some states have thought through sustainable funding options, and the license plate fees that we're seeing in Kentucky are one to potentially look at. Additionally, there's some exciting movement in North Dakota. As the other week, the Senate passed Senate Bill 2149, which would create a 988 fund and includes a fee of up to 30 cents. So this one was particularly interesting because the committee had actually voted out a recommendation of do not pass, but the full Senate did pass this bill. So it's now in the House. When I finish giving my updates, I'll drop a link in the chat where you can follow along to see when a House hearing is scheduled. I know our Crisis Center First Link in North Dakota is really leading the charge there on the advocacy front, and there's ways you can submit testimony if you're from North Dakota. And then my final update, I wanted to share that yesterday, Governor Shapiro in Pennsylvania included 988 funding in his budget address proposal. In addition to $5 million one-time funding for 988, he also proposed to include a 2.95% 988 percentage for 911 fees on surcharge, the 911 surcharge. So we are again looking at some of those creative funding options that states are taking a look at, and that's one we wanted to highlight. With that, I will turn it over to my colleague from NAMI, Stephanie.
Thanks so much, Caitlin. And as you can tell from Caitlin's update, there's a lot happening at the state level. This is certainly not a full rundown of things that are happening. We just wanted to focus on some of the newer bills and those that have a major financial impact. A few other states we wanted to mention: Ohio. So Ohio State Budget Bill, House Bill 33. Includes a line item to fund 988 at 20.7 million for the next fiscal year and 25.8 million the year following. They do a 2-year budget, so that would be 46.5 million in total. Notably, if this were passed as it's written, that would kind of establish going forward with Ohio's budgets a line item for 988, which would certainly be a great thing. Also, Vermont, you see now in yellow and also along with Rhode Island, though it's a little hard to see. So they have new legislation. Vermont House Bill 283 was introduced. This really encompasses the 988 model bill provisions that we're used to. I will note something unique about this bill. It also establishes a suicide fatality review team to review, educate, and make recommendations to help prevent future deaths by suicide in the state. There's also trainings for school faculty and staff members on 988 and a requirement to add that to student ID cards. Beyond the 988 fee, a couple other financial implications of this bill: there would be $6 million for peer respite systems and 1.8 for general suicide prevention activities. And rounding us out here, Rhode Island, that new bill is H6121. So you might remember that last session, Rhode Island had a 988 implementation bill. So this is a new updated version of that, notably creating a 988 telecommunications fee. The specific amount is not mentioned in the bill text at this time, but hopefully we will see that measure move forward this session. And that wraps up the state update for today.
Well, thank you so much, Steph and Caitlin. I just want to also note, again, you do not have to remember this information. There are links in the chat where you can go and find those lovely maps. And I also just want to make the case, you know, we heard from Seth and Tanja around structural stigma. This is an opportunity for folks to be involved at the state level, local level around crisis services and why it's important for that investment. So with that, I'm going to turn it over to Paulo Del Vecchio, who's with SAMHSA as the Director of the Office of Recovery, to share a little bit of his lived lens.
Great, thank you. Hello, and thank you everyone for your work in improving crisis response across the nation. I've personally experienced crises from mental health addictions and trauma on a number of occasions during my lifetime. Traumatized by being taken away in the back of police cars and restraints, feeling shame, fear, and pain. I'll share one particular occasion where it was one of the worst times, wanting to end my life without hope, without friends, without a job, feeling without a future. It was also without choices of where to go for help. The one and only option was a mental health intake center in the town I was living. Somehow I found the last of my energy and my courage and found my way to the door of that center, a big gray steel enforced door of a drab cinder block building in a rough part of town. I was buzzed in through the security, and the first person I saw was a uniformed officer scowling with his arms crossed, who told me to take a number. Scared, I was alone, full of anxiety, racing thoughts. I looked around the cold and clinical interior, dull white scuffed walls, bulky waiting room chairs, the plexiglass partition, separating distraught patients from unsmiling and tense staff. I took a seat and waited and waited and waited. My fears growing by the minute. Would I be restrained again? Would I be forced into a hospital? Would I be given meds that I didn't want? Would I lose my housing? Would I lose my family? Finally, my number was called. I went to the plexiglass window where I told the intake staff the intimate details of what was happening to me in front of the other staff and patients. The staff person told me that they had no appointments and to come back in a month as there was an opening then. I turned around feeling more hopeless than when I came in, and I left through that gray door never to come back, nor was there any follow-up by the center to check on me. Sadly, of course, my story is not unique, as many will be turned away when we seek help. We will know we will have improved crisis response when we truly practice recovery-based, trauma-informed crisis care. This means we have access to on-demand care that's brought to us in our homes and communities. When we are given meaningful choices, when we are treated with respect and dignity, when we are safe and feel welcomed, when we have our rights protected, when we are asked what happened to us, not what's wrong with us, and we are not re-traumatized, when we are provided with peer and family supports of people who've been there and can help us walk through it, when we are provided with holistic care to address all of our needs, and most importantly, when we are given hope that we can overcome this crisis and continue to our journeys of recovery. My story, I was lucky. For as I was walking through that gray door, as I was leaving, I saw a sign, literally a sign on that door for a part-time job at a worm line. And I found peer support. I found purpose. I found recovery. I was fortunate. Many others aren't, and we lose far too many. It doesn't have to be this way. If we embrace recovery-based, trauma-informed crisis care, thank you all very much.
Thank you, Paulo. Thank you for all the work that you've done with SAMHSA, without SAMHSA. Really appreciate and glad to see that you're back in the Office of Recovery. So at this point, I'm going to turn it over to Steph Hepburn to give us a sneak peek of the crisis talk. So Stephanie.
Thank you, Laura, and thank you, Paulo. That was Incredibly moving. Thank you. I'd like to welcome Mina Dayak. She's the practice director at McKinley Advisors. Mina, you've shared that 988 marketing must be data-driven and look at the entire 988 crisis care continuum. Can you tell me what that means?
Sure. So I think we've already heard a lot of great stuff today that points to what we're looking at. In order to really grow awareness of 988 and the value that it provides and who can use it as a lifeline, we are going to need a massive marketing campaign at the level and of the intensity that Seth described at the beginning that the Huntsman Initiative is doing. And that campaign has to be very data-driven because we have to reach the entire nation, and we have to reach so many different segments of the population. So really knowing where having the data on where the need is the greatest. Obviously the rate of suicide and the instances of mental illness and people needing help, we see a lot of that happening among the youth. So just knowing where the pockets of greatest need and greatest crisis are and being able to meet these different segments of the audience where they are, right? Like the way you market and raise awareness to youth is going to be very different from the way you reach maybe older people or people in different stigmatized sections of society. And it could be people who come into contact with the mental health system, or people who never have, people who are just at their primary care doctor, like presenting with conditions, or people who just don't come into contact with the healthcare system at all, and who still need to know that there is this lifeline that they can call and get help from. So really understanding the audience is an important data point. And the other thing we want to understand is where we want to be sure that we don't overpromise in marketing. So as the systems and the support structure is being built up to be able to service the 988 calls and to be able to help people in crisis, we want to make sure that that infrastructure exists before it is promoted locally.
And, when we were talking, and earlier, Laura was talking about the Utah dashboard, that public-facing dashboard that looks throughout the entire crisis continuum. And I know NRI has been tracking these initiatives, and what they found is that there's less data that's being collected at the crisis stabilization level, the 23-hour crisis stabilization facilities. Can you talk a little bit about, why looking at all of those different components is so critical in terms of deciding when to ramp up marketing?
Yeah, I think the most effective campaign for something like this should start and should really be scaled up at a national level and then cascade down to states and to local regions. But exactly where it is played out and how it is adapted locally it's very important to know that that infrastructure, as we talked about, is in place, and to be able to track and to see at what points we need to raise awareness, right? If people are calling 911 and if calls are still coming in that way, and if that's where support is needed, how do we message and how do we encourage people to directly call 988 in future? How do we ensure that support is available wherever you're looking for it? And obviously, the most important component of 988 is as a suicide prevention lifeline. But if you look at it, it's also a way to erase the stigma that we've been talking about on today's Crisis Jam. It's a way for people to just get help if they're struggling with emotional, mental health kind of challenges, even if they are not having thoughts of suicide, right? So
increasing public awareness.
Just public awareness. And how do you really scale this up? How do you ensure that the right supports are in place and that sort of follow-up customer service? If people see this marketing, if they see the Super Bowl commercial, if you will, for 988 and call in times of need, you want to make sure that they will get the right kind of support because the systems are in place. And we know that that ramp up is going, a lot of tremendous work is happening, but as we just heard in the state updates, different regions and different states are in different states of readiness. So you want to make sure that the cascading down of that national campaign matches where they are in terms of being able to stand up the structures.
Thank you so much, Mina, for hopping on the call. Thank you. I'll pass it back to you, Laura.
Thank you
Thanks.
all.
Thank you, Stephanie. And actually, if I could just take a point of personal privilege, Mina, can I ask you to talk a little bit about your work? You also have a very storied background in crisis services. Could you talk a little bit about your work with National Council and what we might extrapolate to 988?
Absolutely. It's been a while since I worked with what is now the National Council for Mental Wellbeing, but I had the privilege of being there when we brought mental health first aid into the US. And that to me was a lesson in how we could really sort of spread awareness by empowering people, by giving them the ability to actually do something if they saw a loved one, a coworker, somebody around them in distress, how they could take action, how they could support them, how they could triage and provide first aid, if you will. And having brought that program in just gave us the ability to talk with the public. And we at the national level were able to create materials for awareness. It wasn't just the educational component, but we also were able to provide marketing ideas, marketing toolkits, marketing materials that could then be used at the local level by the instructors, by the community behavioral health centers that were actually running that program. And it really helped a lot. It was that great synergy between what could happen at the national and the local level to be able to cascade that down. And I think it went a long way towards eradicating stigma. And there are many, many efforts going on, but having the power of, as Seth was describing, having the power of so many different powerful organizations coming together along with federal government, along with the ad council, along with sports leagues, along with celebrities, along with people in every industry you can think of. That I think is really what adds to the power of a campaign like this. So yeah, my background, I am not I'm not a mental health or substance use professional like many of you on this call, but my background is in marketing, and I've seen how a dedicated effort to spread awareness can really, really advance the cause.
Yeah, well, definitely very important as we talk about scaling and marketing 988. And you also mentioned data, so I'm going to turn it over to Dr. Matthew Goldman, who heads up our data corner.
Thank you, Laura. And again, an amazing jam today. We are introducing a new subsegment of Data Corner today, which is our Data Corner Journal Club. So this is where I'll go through a few recent important articles in the research literature related to crisis services and talk about some of the key findings. There is a robust literature on the Veterans Crisis Line, which of course is part of the National Suicide Prevention Lifeline Network by pressing 1 when you dial 988. Every researcher you talk to will tell you what a pleasure it is to do research within the Veterans Affairs ecosystem because their data are so nicely linked and organized. And it's a real opportunity to understand crisis services. The VCL responds to 650,000 calls a year. It's been part of the National Suicide Prevention Lifeline since 2007. And the VCL really plays a central role in the Veteran Affairs suicide prevention strategy. And it's critical because over 6,000 veterans died by suicide in 2020. And there's been 20 consecutive years where over 6,000 veterans have died by suicide. 125,000 veterans have died by suicide since 2001, a really staggering number. And suicide is the second leading cause of death in veterans under age 45. So some of the studies that I'll highlight, there are 3 papers that I'll do a whirlwind tour here. The first came out in 2021 by Hanneman and others, where the authors assessed outcomes from almost 160,000 patients who called the VCL between 2010 and 2015. And they did a regression analysis that looked at suicide-related behaviors through 12 months. And what they found is that suicide rates over the next 1, 3, 6, and 12 months were very highly elevated. 797 out of 100,000 people who called VCL dying by suicide in the 1 month after calling the phone line is a really high rate. They also did an analysis where they adjusted for covariates and found that suicide risk was greater among male callers and among those whose calls were categorized as high or moderate risk. So the too long didn't read takeaway is basically that that suicide rates are very high within a month and remain substantially elevated through 12 months. And these findings have really helped inform veteran affairs policy. Okay, on to the next one. So this study by Peter Britton and others, which was published in the American Journal of Preventive Medicine, did a comparison of symptoms before and after calls to the VCL among 650 veteran callers. So how were symptoms before they called and then after they called? They did a linear regression, and they found that there were 5 times greater odds of a reduction in distress, a 5 times greater odds of a reduction in suicidal ideation, and an 11 times greater odds of reduction in suicidal urgency. And so again, the too long didn't read is VCL callers experienced significant reductions in distress and suicidal ideation during the call. So really important proof of the VCL concept itself as being effective. And the last one, because I know we're at the last minute here, is a paper that looks at outcomes after a call to the VCL, where call records and medical records were linked for 600 callers in 2019. And again, after doing a model, they found that 85% of callers made contact with healthcare and 79% made contact with behavioral healthcare. So significant contacts with a subsequent healthcare provider after contacting the VCL. 6 times more likely to make contact with healthcare in the month after than the preceding month, 10 times more likely to make contact with behavioral healthcare in the month after calling the VCL compared to the prior month, and increasing days engaged in healthcare. So again, VCL really increasing contact and utilization of healthcare and behavioral healthcare services. So this last slide here is a complete bibliography of VCL related research. There's a lot of work that's been done in this space, and I'm sure more to come.
Well, thank you, Matt. And again, you don't have to remember that bibliography. You can go to talk.crisisnow.com. I said we were going to do 3 things: have fun, keep it moving, and end on time. 2 out of 3 ain't bad. Next week, join us for Ron Bruno, who's going to talk about mental health should not come in a police car. And remember, if you're in Hawaii or Arizona, with the change of daylight savings, that does not apply to your states. So we will start an hour earlier than usual. So noon Eastern for everyone participating in daylight savings, 11 for folks in Arizona and Hawaii. Thank you all so much. Appreciate you spending this hour with us and hope you have a great day.